As Albert noted, I've been looking at dead pigs for quite some time and have a real passion for helping clients out and answering questions. And so I'm going to talk today about the applications for next generation sequencing and probably some things we should think about as we go forward. So again, I'm just going to talk about the applications of next generation sequencing. And when I started to put this presentation together, it was last night, but as most of us, a lot of us do anymore, I remember a talk I gave in, I think I'm going back here. I remember a talk I gave back in Hershey, Pennsylvania, right about 15, 16 years ago, on how do you, what are the applications of PCR and what are the applications of PRSV sequencing, and virtually it's very similar to what I talked about back then, in part because it was new, people didn't know how to apply it, and gone through a thought process about how to apply it. And for the applications for next generation sequencing, they're really kind of straightforward. We want to know what's in there, we want to know what's important. Problem is, infectious diseases aren't very straightforward, and cause and effect is the more we learn, cause and effect is difficult to understand. In the past, when we had really sensitive tests, infectious disease research was a lot simpler. We found out something that was the cause of clinical problems, and we didn't have any appreciation for what else may be going on in that pig. And if that approach had worked, we wouldn't be talking about any of this today. So obviously we haven't been answering the questions in the past, and it's still going to be a struggle and frustration as we go forward. So what do we want? We want immediate actionable results. Then sample in, we want to know what's there tomorrow, and we want to know if it's important. Broad range of specimen types. We want to send in oral fluids, tissues, serum, whatever may come to mind. We want to send that in and have all these answers available. We want to find everything that's in the sample and correlate that with the clinical presentation. And we also want to understand the dynamics of the infectious diseases present. How are they going to act? How are they going to interact? What kind of prognosis or predictions can I make from these findings? So just briefly, Doug and Ben have talked about this. Just a list of the presentation of the process that samples go through. Patients or pigs come in. Data about that case is entered into the laboratory information system. We need to know a lot about this, about what's normal, what do we have out there, what's available for comparison against, and this strongly influences how we can apply importance to those specific pathogens. So samples go into the process, you get your pathogens accumulated in a database. We use that database for analysis. We use the normals that we have. We put back what we find into the pathogen database, and eventually we'll come out with some answers. So applications of next generation sequencing, again, as I said before, we want to know everything that's in a sample, and we want to take a sample and send it to the lab. This slide represents serial samples taken from a woman in China with an H9 influenza virus infection. And it's a busy slide. I'll explain it a little bit. These color-coded bars here represent neutrophils, lymphocytes, and other white blood cells taken in time, all from bronchial alveolar lavage samples. The black line is the amplification of the influenza virus from those bronchial alveolar lavage samples. The top lists treatments with different antivirals and different antibiotics. And then these circles correlate the different bacterial pathogens, the percentage of bacterial pathogens retrieved from those samples. And so as the patient progresses over time with antibiotic treatment, there's different number of bacterial pathogens that come out of there in different percentages, and it kind of progresses toward this bacteria species here. But again, depending on time when you find it, when you look for it, you find different agents. And then ultimately the patient died. Okay, when we get samples in, you want to know who has what. And so does it matter what sample you take? And is there a difference between a person versus a barn full of pigs? So if we go back and look at this same chart, and you send a sample in and you want to know everything that's in there, well, it kind of really depends on when you take your sample. So if you've got a chronic pig, you send it in, I want to know everything that's in there. It's going to be different than when you're looking at an acute infection and you say, I want to know everything that's in there. Then along this line, I think as most of us know, every pig in the barn isn't the same. They aren't at the same stage of disease. And so, again, how do you apply your sampling? Looking for everything that's in there, finding the right pig, the right time, or how many pigs you want to look at to find everything that's in there. So, then what sample do you take? To answer your question, do you take oral fluids? And how will that represent the pathogenesis of the disease problem going on? Do you take serum, knowing that some infections may be transient in the serum? Do you take tissues every time? Do you take fecal samples? And so trying to relate these again back to who has what and when do they have it can be difficult. And again, part of the frustration that we're going to come across trying to understand these, understand the results. And so again, sorry, say again? Oh. So, yes, no, sometimes I don't know. Probably I don't know is the more common answer because as Obert related with sequencing curves from normal or not clinically severe pigs, we don't know what normal is. So if we don't know what normal is, we can't do any comparisons. Again, just going back to this same chart, if you start to overlay this chart for a bunch of different pigs in a barn, you're going to get a really confusing mess and a lot of frustration on trying to understand what's going on in those pigs, what's important. Then also remember sometimes what we tend to overlook is that organs are interactive. No organ exists by itself. So when you're trying to understand the pathogenesis of a disease process, especially we're at the point in time now where we can start to find lots of different things. What's the effect on respiratory disease from the microbiome in the small intestine? Has microbiome changed, affecting immunity? Does that have an influence on respiratory disease? Pigs go off feed. Feed consumption changes that then have a secondary effect on the intestinal biome and a subsequent feedback on the immunity for the pig. So lots of things going on that we can measure. We just don't are at a point in time to have good answers for all the things we're finding. So just briefly, what I wanted to point out on this slide is that metagenomics, RVP stands for Respiratory Viral Panel, are very good at finding everything that's in a sample. They have a very high agreement with a prior respiratory virus panel, so the respiratory virus panel are samples that may run individual or multiplex PCRs on. And again, the information you get back is pretty thorough and identify a lot more than we have identified to date. Again, just a further validation of the power of metagenomic sequencing and identify many diverse pathogens, overlapping system symptoms, and then also has been alluded to identification of antibiotic resistance genes. And again, I've got all these listed in the references at the end of the presentation. The slides are available from through the Leman conference. So, again, just some nice comments about some of the issues associated with metagenomic sequencing or next generation sequencing, in this case applying to cytomegalovirus in people. We need strict criteria for differentiating between strains, large, well-controlled studies, and standardization of molecular techniques. So we're all working from the same starting point. And so probably a little more of what I want to talk about or get into today is trying to understand what's going on with understanding the results from these. So classically, we get an isolate bacteria virus, and we put it back into pigs that know or think we know that they're negative for it, and that's how we understand what we expect to see on histopath. When to collect samples, do we collect them from the serum, do we collect them from the feces, do we collect them from nasal swab or conjunctival swab? So when we're finding all these things, how do you perform a pathogenesis study when you've got 6 different viruses coming out of the pig? How do you conduct a pathogenesis study when you don't have any idea on what the sequence of infection is going to be? Is it important that these 6 viruses, you have to get viruses A and B first to make viruses C and D show their clinical disease? You need to get virus A and then virus D. So when you start to try to pull it apart, it gets really complex. And if you don't understand what's going on, who gets what when, how do you intervene? If you can't do normal pathogenesis studies, tearing these apart, it's really difficult to understand, again, what's going on in these pigs. Go back one thing here. Pathogenesis studies, again, I did, when you can't grow organisms, viruses is what we talk about a lot. How do you do a pathogenesis study when you can't grow a virus? You have to grind up tissues to find the virus, and in that case, the tissues you're grinding up may have 2 other viruses in it that you're not aware of or don't know of. And so, again, it becomes really, really complicated, really fast, trying to understand what's going on. So what we need to do, this is a quote from one of the articles, and one thing we need to do a lot better on a routine basis is getting a good clinical history, applying clinical findings, outcomes from groups as they finish out. And we need to be able to collect this in a standardized manner. It needs to be deposited somewhere, so multiple researchers, clinicians, practitioners can go back and search that data, add to it, and try to slowly chip away at trying to understand new diseases and viruses that may be coming out into showing up in pigs. One thing that we haven't done, we need to do on a more recurring or regular basis is understand the variation in host genome, especially as related to infectious disease response. The perception, or the comment I get once in a while is that pigs, this is all same breed pigs, the same genetics, why should we take that consideration? Well, if you look at the complexity just of even antibody formation, you'll see that even in pigs with the same genetic makeup, we can't predict everything by the known genetic makeup. We need to look at this more in depth, find a better way to profile how the pig responds in certain different situations, whether it's antibodies, whether it's antiviral response to them. And we need to know what normal is. It's been the basis of pathology forever, is that if you don't know what normal is, you can't tell what abnormal is. And it's just about that simple. Again, related back to that chart about the limit of the influenza virus, how many samples do we take? Can you make a diagnosis with one sample? We're looking for all these new viruses. And again, depends on what answer you want to have from those samples. If you just want to know if a pig has PED or not, that's a really straightforward, easy sample. Generally, you just want to take one fecal sample and you can find an answer to that. As I mentioned, how do pathogens transition? If we know acute pigs have this bacterial population associated with an influenza virus infection, we have a treatment protocol for that initial bacterial infection. If we know, we take those pigs that don't respond and we then test them by metagenomic sequencing. Do we get a consistent or average response in the different bacteria that are present, that we can initiate a more knowledgeable secondary intervention on those pigs that fail to respond to the first treatment. And if you haven't thought about it by now, we're trying to figure out what normal is, who has what, when did they have it. We collecting samples all the time. And that's not easy to do for people in the barns, and it's certainly not easy for us to have every pig sample on a regular recurring basis. We'll have to grow quite a bit. And that's what Jerry's here to do. Again, along the line of finding out what normal is, to find out the effect of some of these new viruses we find, do we need to do regular routine testing to know what normal populations of those viruses are? And so if we have a known set of normals, then if we test sick pigs and we find a new virus, that may be one way to identify the importance of different viruses in a sample. What about if everything's the same? You take samples, what normal is, now you have sick pigs, and everything you find in there is the same, but perhaps it's just a percentage difference. So we have, for example, rotavirus that you normally look at has a certain profile, and all of a sudden, instead of 5%, 5% of the rotavirus in the fecal sample, now you've got 35%. So there's another method that you can use or think about to try to identify just variations in normal pathogens that are present, and then try to figure out what happened to cause that specific virus to go much above the normal percentage you would think. So none of these questions are new. These are the same questions we've always been trying to answer. I think with the next generation sequence or genomic sequencing, we have an opportunity to try to answer some of these questions. Sometimes it might be easy. Most likely it's going to be complicated and very frustrating to figure out what's going on in our sick pigs. We still need to understand the pathogenesis of disease. That's one thing that doesn't go away. It's on cases like that for next generation sequencing, we'll find something and the client calls me up and says, what does this mean? And sometimes I have to say, I don't know. We don't have enough information, don't have enough background to find out, to understand what's going on. So, learning from the past, with per sequencing, and especially, we had all kinds of great expectations with per sequencing to find out, how we can cure it, how we can get rid of it. If we just sequence enough viruses, we'll figure things out and make it go away. Well, per sequencing has been very important. We've learned a lot from it, but it didn't answer all our questions. So I think we need to be patient with this new technology. We need to think more about how we're using it. I think we need to manage our expectations with it, and then specifically understand what question you're asking. So if you're just saying, I'm frustrated, I want to know everything that's in here, I don't know how much good we're going to do you, at least from what we know now. If you think about this and have a specific question that you want to have answered, understand where you need to measure, who you need to measure, what kind of sample you need to take, then I think we'll have make more progress and have less frustrations with new technology that we had when we first started doing PCR and virus sequencing. And these are a list of the references, articles from my talk. And certainly these are going to be available through the Leman conference if you want to go in and read them.